guys, it's Lizzie here. Today we're going to go through how to set up an arterial transducer line. There's, I guess, a couple of principles. This is not necessarily the only way you can do it. There's a couple of principles you need to abide by, however. The first one is ensuring that the bottom half of the line, so that's from the blood aspiration lever that you pull back to get blood back in your line to take a sample, from that component down to the bit that connects to the patient needs to remain sterile. So however you do your line, that needs to remain sterile, because the line itself gets inserted under sterile conditions, and we need to ensure that we're not going to introduce an infection to the patient. So no priming the line and hanging it over an IV line or touching it with like normal wall gloves to get it ready. You need to do it in a way that maintains that sterility. So you can either do it in the way that I'm going to show you today, which is convenient because you can do it in your own time at your own pace and just leave it sitting on a sterile dressing pack ready to go, or you can open your arterial transducer kit onto the doctor's sterile field when they're doing the arterial insertion line, get them to hand you the spike, you spike the bag and then they prime the line, but that comes with its own set of problems. And some people, I notice, open the pack and leave it in the sterile pack and just pull out the spike bit and prime it that way. So as long as you're maintaining that sterility, that's, I guess, the most important principle. The second thing that's really important is the actual priming itself and ensuring that you don't entrain air into the system. And that's because air bubbles in your transducer line actually affect what we call damping, which is related to the trace that you see on the monitor. And even one or two tiny little air bubbles can affect this, and that's going to affect the accuracy of the numbers that you're being shown and that you're basing other treatment decisions off. So it is really important that you prime the line in a way where you don't get any air bubbles. All right, so the first thing I've done here is I've gathered my equipment. I have an IV pole, I have a pressure bag, and I have the arterial transducer holder. So this is the bit where we actually put the transducer component, and we're going to move this up and down the pole to level it to the appropriate area. For most of our patients, that's going to be the phlebistatic axis. For some of our patients, it's going to be the tragus or the external auditory meatus. That's usually only in the event of a traumatic brain injury, where we're monitoring and targeting a CPP or a cerebral perfusion pressure. The other equipment I'm going to need is a dressing pack, a set of sterile gloves in your size, a 500 ml bag of saline that is in date, that you've checked with someone else, because the medical team will prescribe this on intensives in your inputs at 3 mils per hour, which is what we're delivering when the bag is blown up, the pressure bag is blown up. So we need to sign for that. A little bit of tinted claw hex. You don't need a whole bottle, just a little bit to get a couple of pieces of gauze covered. And finally, you actually need your transducer kit. Be mindful, in our unit we have 2 transducer kits. We have one with a vamp and the blood aspiration lever, for want of a better word, or component, and that's the one we typically use in arterial lines. There is a kit that comes in a package that's about half the size of this, and that doesn't have that blood aspiration component. It is literally just the transducer setup, and we would use that for things like a CVP. So important to make sure that you get the right kit. So what I'm going to do now is I'm going to go ahead and get myself ready. So I'm going to get my normal saline bag and I'm going to pop it in my pressure bag. So I'm just going to insert it and hang it on the hook in here. What you should really be doing is popping a little label on this with the date and time that you're starting the infusion. These bags do get changed every 24 hours as a minimum. Sometimes you will need to do more if you're doing frequent blood sampling, and that's because the amount you're flushing to the patient is quite a lot. These bags need to have a pretty full level to, again, have an accurate reading. At this stage, I don't blow the pressure bag up. I leave it down, because when you blow the pressure bag up, when you're priming the line, it makes the saline go through the line really quickly, and it's very easy to entrain air and capture little air bubbles in your system. It is okay to prime it blown up, but I would suggest, as you're learning, or if getting air in your line is something that happens to you all the time, don't blow the pressure bag up until the line is primed and you're ready to connect it to the patient. All right, I'm going to set up my dressing pack, and we've all done this 10,000 times, so I'm not going to talk in detail about how I do this. I've got my bin there ready, and obviously I would have cleaned my table before I started to ensure that I've got a nice clean surface, whether that's a table like this or a dressing trolley. It's whatever we can get our hands on. I personally always use my yellow tongs to get everything out of my tray and put it on my sterile field where I want it, and then I'm going to throw those out. I'm going to put a little bit of Chlorhex on my doors. Again, I don't need a lot. I'm just going to use this to hold my bag like I would if I was doing doing a line change for a central line infusion. Now open my bag, keeping my transducer line, keeping everything nice and sterile, and just tip that out. Put that away right there. And then I'm just going to set my gloves up and my sterile towel to dry my hands after I've washed my hands. If you're a hand washer, if you're using gel, you obviously don't need that component. All right. So now I'm going to go away and either do my hand gel, ensuring appropriate technique and drying time, or do my 2-minute hand wash and dry my hands using a sterile towel. And then I'm going to come back and I'm going to pop on my sterile gloves. So I'm just doing this a little bit side on. So and again, we all have our own technique for how we get this done, but as long as you're maintaining that sterility, that's the most important thing. All right, and so now what I'm going to do is get everything ready on my dressing kit here. I'm nice and sterile, so I can do this. You'll notice that the arterial line itself comes kind of packaged with some tape around it. So I'm just going to pull these white bits of, it's almost like paper, off the arterial transducer line and get rid of it so it's out of my way. And so this bit that I've just undone is the spike bit. So this is what we're going to spike our 500 ml fluid bag with. I'm actually just going to move this clamp down and I'm going to clamp that off. Okay, so when I spike it, I don't get fluid running through because I want to get it. It's exactly like priming an IV line. I want to fill my chamber first or halfway up. The next thing component I'm going to look at, so I'll just hold this up, and I apologise if I accidentally touch something that's not sterile and demonstrate it badly. Hopefully I can avoid that. So these are your two middle components here. So for those of you who are not particularly familiar with arterial lines, this here is the, the lever I was talking about. It pushes in and it pulls out. This is what we aspirate back to get a blood sample back. Okay, and that means that on this port here that's down near the patient access, we can take a blood sample. This component here is the actual transducer. So this is the bit that we need to zero to atmospheric pressure at the phlebostatic axis or wherever we're monitoring blood pressure. So this is the bit that we open, and you can see that's where all the electronics are in the back. Okay, and this little blue tab here, when I pull it, it opens a valve on the inside and it allows, it's called a fast flush tab. Basically, that's how we flush the line with the saline fluid that's going through the line. All right, so the one other thing I need to do to this line to get it ready, these clear caps that come on the line are actually vented caps. They're open to air. So if you don't change that, what you'll find is because your normal saline that's going through here is in a pressure bag, so it's being delivered under pressure, you'll get this dripping of fluid out through this vented cap, and you can also entrain air in the system that way. So when you're setting it up, you need to change that cap to a non-vented cap, and there's a white one that comes in the pack. If for some reason you've come across an arterial line that's already been set up and it still has the vented cap and there's no white cap, use a red one. So use the red caps that you can find in the unit. So I'm just going to do that now. I'm going to open this up. I'm going to keep my stickers because it's good practice and we should be labeling all of our lines that go into patients. So you've got a number of options on these stickers, and this one's I'm setting it up for arterial, but if I was doing something else, I could label it appropriately. So I'm going to put this arterial sticker on my actual plastic tubing somewhere up near the top so I know that it's arterial, just like we do with our IV infusions. I'm going to change my cap, my vented cap. over, so I'm just going to untwist that. And this is also a good time if you want to check your tightness of all your connections. Sometimes these things come out of the pack and it's all a little bit loose, particularly here. You can just check that. All right, so now what I'm going to do is I'm going to do step 1, which is to spike the bag. Now I would normally have opened that tab before I got sterile. I've forgotten, so my 2 options here, the safest one is to ask a colleague to come over and pull off the blue tab so it's open to saline. I don't have the luxury of that here today, so what I'm going to do is I'm going to just use some Chlorhex soaked gauze to hold it to maintain my sterility with my gloves. Now I have just touched that bag with my right hand, so I'm really conscious of that. I'm going to try and not use my right hand to do anything that's touching a clean line now. I've already clamped this line off, so now I'm going to unspike it. I'm going to get some more Chlorhex soap gauze here. Yep, and I'm going to spike my bag. Like I said, exactly like we do with the central line. Okay, and now I'm just going to squeeze this to get a bit of fluid about halfway up the drip chamber. You can see that there. Okay. Now remember what I said at the beginning, if you're doing this a different way, the main part to keep sterile is from this part down to the patient connection. So this is the half we really need to be mindful that doesn't get contaminated or dirty, but hopefully doing this way you're keeping the whole line nice and clean. What I'm going to do now is I'm going to start priming, and I'm going to hold this up so you can see it really clearly. Just let me untangle it. So I'm going to be pulling this blue line to do the priming, and you'll notice depending on how hard you pull the blue line, sorry I haven't unclamped it, let me unclamp it. Depending on how hard you pull the blue line will depend on how fast the saline flows through the system, and I've just pulled that quite fast, so I can already see I've got a couple of air bubbles in my line. So what I'm going to do, again, different people do this different ways, but I leave this, what am I going to call it, this vamp lever thing that we aspirate back to get our blood sample. I'm going to leave that open because what I'm going to do is I'm actually going to use this kind of like a blood pump giving set to try and capture all that air and to get it to float to the top. So you can see my fluids coming through, I don't have much gravity happening here because so I'm just going to drop this down a little bit. You can see there I've kind of angled it, so I'm going to get all the air out first, and now you can see that fluid coming out. I'm going to finish priming my line. Now when I get to the end, now I'm just going to point this into my kidney dish so you can see it, but when I get to the end it will prime out through the end. So if you've got air bubbles, you can just keep like holding open your fast flush valve or your blue tab, just keep pulling it until you've got all of your air bubbles out. It is really quite important that you go to like a great deal of effort to get your air bubbles out, because like I said, that's one of the very first things we want to troubleshoot when we think we've got an inaccurate trace or our damping is an issue. Now 2 things, you can push this closed now that it's primed, or you can wait until it's connected to the patient, which is often what I do, because you know it's an arterial line. The doctors have aspirated blood through it. Sometimes when they take the syringe off to connect this line, they haven't clamped it, whatever, you might have some blood sitting in the arterial line. So I find once we actually go to connect this to the patient, I then push this in, give a really nice, you'll see, big flush through that arterial cannula that's in the patient. Yeah. And then I've got a nice clear arterial line. I can then hook up my actual pressure cable. Okay, I'm going to ensure, so I take my gloves off. I'm going to leave that there nice and sterile for the medical officer to now connect. I'm going to ensure on my pressure bag that I now open the valve to air and I blow this pressure bag up to the appropriate level. So we just want to ensure that it's in the green range. I'm getting a bit of sore arm there. It's my gym workout for the day. Here we go. So always ensuring you're in the green range, you're not over inflating your bag, okay? And then we're going to close it off so air can't escape from the pressure bag. Once the actual arterial line, so the medical officer has inserted the arterial line to the patient, they're going to connect to this end. So they're going to take that cap off, they're going to connect that to the patient, secure it, apply a dressing. We can then, because now we've got a closed circuit to the patient, we can come and touch this. We're going to pop our transducer, this in the holder. We're going to attach our arterial pressure cable to our GE monitor, and we're going to zero the line. All right, I hope that's helpful and that you feel more comfortable with setting up an arterial line.